Welcome. In this session, we are going to talk about phacomatoses, which are also known as neurooculocutaneous syndromes, and they are a group of congenital syndromes characterized by hamartomas of the skin, the central nervous system, and the eye. Apart from hamartomas of these organs, they can also have benign and malignant acquired tumors in these organs as well as other organs. They do not have sex or racial predilection except incontinentia pigmenti, which being an X-linked dominant disorder occurs exclusively in females. Life expectancy is reduced in most of these entities, and suspects and patients of these disorders require diagnostic evaluation periodically to detect development of new lesions over lifetime. Neurofibromatosis type 1, also called NF1, peripheral neurofibromatosis or von Recklinghausen's disease, is an autosomal dominant disease with incomplete penetrance due to loss of tumor suppressor gene NF1 present in chromosome 17. Ocular features of neurofibromatosis type 1 include lesion nodules, which are small, tan to brown well-defined nodular excrescences on the iris as seen here in these photographs. On a dark-colored iris, they appear lighter, and on a light-colored iris, they appear darker than the iris. They start to appear after 5 years of age and are found in all adults with neurofibromatosis type 1. Histopathologically, they are composed of closely packed dendritic or spindle melanocytes in the anterior iris stroma. Other ocular features which can occur in neurofibromatosis type 1 include prominence of corneal nerves, which occurs in less than 20% of patients with this disorder, choroidal melanocytic nevi, which are usually not visible ophthalmoscopically but can be picked up by near infrared photography, and retinal astrocytic hamartomas, juvenile xanthogranulomas, and retinal capillary hemangiomas. As we will be saying, retinal astrocytic hamartomas and retinal capillary hemangiomas are more characteristic of other phacomatoses. Neurological features of neurofibromatosis type 1 include optic pathway glioma involving the optic nerve or the chiasm or both, and which can occur bilaterally. These two photographs show optic pathway gliomas as swelling and kinking of the optic nerves. We have discussed optic pathway gliomas in detail in session 6 of neuroophthalmology. Subcutaneous neurofibromas can occur as pedunculated neurofibromas as seen here in this photograph, or as diffuse plexiform neurofibromas as shown here in this photograph involving the eyelid. We have discussed diffuse plexiform neurofibroma in more detail in session 10 of oculoplasty section. 50% of plexiform neurofibromas involving the upper eyelid can have unilateral glaucoma. Other neurologic features of neurofibromatosis type 1 include localized orbital neurofibromas, sphenoid dysplasia as seen here in this MRI photograph, which shows absence of the sphenoid bone, and this absence of sphenoid bone can cause pulsatile proptosis. And neurofibromas can also occur in the central nervous system, which can lead to seizures, focal neurologic signs, and learning disabilities. Cutaneous lesions of neurofibromatosis type 1 include scaphe-olite spots, which are uniformly hyperpigmented macules. They are small in early life, but they gradually enlarge in size. 6 or more such spots larger than 1.5 cm in diameter in postpubertal individuals is considered diagnostic of neurofibromatosis type 1. There can also be freckling of axillary and inguinal areas, which appear as multiple flat, very small pigmented macules. Other features of neurofibromatosis type 1 include scoliosis and occurrence of malignant tumors such as pheochromocytoma, rhabdomyosarcoma, neurofibrosarcoma, which is considered to be a malignant transformation of a neurofibroma, Wilms tumor, leukemia, and lymphoma. Neurofibromatosis type 1 patients may require treatment for optic nerve glioma, plexiform neurofibroma, and intracranial neoplasms. Neurofibromatosis type 1 patients have reduced life expectancy because of malignant neoplasms, expanding intracranial benign neoplasms, and complications of systemic hypertension. And bilateral optic nerve glioma can cause blindness in patients with neurofibromatosis type 1. Neurofibromatosis type 2, also called NF2 or central NF, is also an autosomal dominant disease with incomplete penetrance due to loss of a tumor suppressor gene in chromosome 22. Onset of clinical features is in second decade of life, and ocular features of this disease include cataract, usually posterior subcapsular cataract or wedge-shaped cortical cataract. These patients also have combined hamartoma of the retina and RPE, which we have discussed in detail in session 2 of this section. Epiretinal membrane can also occur in patients with neurofibromatosis type 2, but unlike neurofibromatosis type 1, leash nodules, eyelid neurofibromas, and optic nerve gliomas occur infrequently in patients with neurofibromatosis type 2. Among the neurological features of neurofibromatosis type 2, bilateral acoustic neuromas, also called vestibuloschwannomas, involving the 8th cranial nerve, is characteristic and pathognomonic of neurofibromatosis type 2. And when these patients develop bilateral acoustic neuromas, they complain of sensory neural hearing loss and tinnitus. Other nerve tumors can also occur in neurofibromatosis type 2, and neurofibromatosis type 2 patients can have cafe-au-lait patches in the skin. Neurofibromatosis type 2 patients require surgical excision of acoustic neuromas and other tumors, and these patients can develop blindness and have reduced life expectancy from expansion or apoplexy of their intracranial lesions. Tuberous sclerosis complex, also known as TSC or Bonneville's disease, is an autosomal dominant disease due to loss of tumor suppressor genes in any of 4 genetic loci, most commonly chromosomes 9 and 16 and less commonly in chromosomes 11 and 12. The typical ocular feature of tuberous sclerosis is retinal astrocytic hamartoma. In very young patients, they appear as ill-defined flat lesions with smooth surface, opalescent or grey-white in color and obscuring the underlying blood vessels. In older patients, the lesions appear as well-defined elevated lesions with a nodulous surface and appearing white and calcified. Because of the nodulous surface, they are also called mulberry tumors. There can be transitional tumors which have combination of both these appearances. Retinal astrocytic hamartomas, as the name suggests, arise from astrocytes present in retinal nerve fiber layer. They do not have dilated feeder and drainer vessels, unlike retinoblastomas, with which they may be confused with. Astrocytomas do not affect vision, and they can show limited growth over extended periods, but do not have malignant potential. Astrocytomas are typically multiple and bilateral in tuberous sclerosis, but astrocytomas can also occur in patients without tuberous sclerosis, in which case they are typically unilateral and unifocal. Giant cell astrocytomas are a rare variant of astrocytomas which may also be found in patients with tuberous sclerosis. They occur in younger individuals and appear as large tumors with progressive serous retinal detachment. They are frequently misdiagnosed as amelanotic choroidal melanoma and are only diagnosed after enucleation. In patients with tuberous sclerosis, hypomelanotic lesions can also be found in the iris or the choroid. Neurological features of patients with tuberous sclerosis include astrocytomas in periventricular and basal ganglia regions which may undergo calcification, as seen here in these photographs. Calcified astrocytomas, also called brainstones, are also visible in plain X-rays of the skull. There can be tuberous malformations of the cortex, as seen here in this photograph, cognitive impairment, and seizures. The antiepileptic medicine vigabatrin has been found to be effective for seizures in tuberous sclerosis patients, but can cause retinal toxicity and peripheral visual field loss, and these patients on vigabatrin needs monitoring with ERG and visual field testing. Cutaneous features of tuberous sclerosis include Ashleigh spots, which are hypopigmented macules apparent at birth, and they are better seen under ultraviolet light. Facial angiofibromas or adenoma sebaceum occur in older children with tuberous sclerosis, and they appear as reddish to brown papules distributed over the nose, cheeks, and the nasolabial folds in a butterfly distribution resembling acne. And the occurrence of cognitive impairment, seizures, and facial angiofibromas constitute the folk triad of tuberous sclerosis. Other cutaneous features of tuberous sclerosis include subungual or periungual fibromas, as seen here in this photograph, and shagreen patches, which are thickened patches of skin occurring after puberty, most commonly located in the lumbosacral area. Other lesions which can occur in tuberous sclerosis patients include cardiac rhabdomyoma, lymphangioliomyomatosis of lung, renal angiomyolipoma, and benign cysts can occur in multiple visceral organs. Currently, MTOR inhibitors, MTOR standing for mammalian target of rapamycin, such as everolimus, is used for the treatment of patients with tuberous sclerosis to suppress development or prevent progression of various tumors occurring in these patients. There are several causes of reduced life expectancy of patients with tuberous sclerosis. The most common cause is renal failure from cysts, angiomyolipomas, or both. The second most common cause of reduced life expectancy in patients with tuberous sclerosis is obstructive hydrocephalus from CNS astrocytomas. Other causes of premature mortality in patients with tuberous sclerosis include cardiac conduction defects and heart failure from cardiac rhabdomyoma and chronic pulmonary insufficiency from lymphangioliomyomatosis. Retinocerebral angiomatosis, also called von Hippel-Lindau disease or VHL, is a highly penetrant autosomal dominant disorder. Being highly penetrant, family history is usual, and it occurs due to loss of a tumor suppressor gene in chromosome 3. It is characterized by hemangioblastomas occurring in the central nervous system, including the brain, the retina, and the spinal cord, and these hemangioblastomas are benign tumors. The typical ocular feature of VHL is capillary hemangioblastoma of the retina, and it is usually the first lesion to be detected in patients with VHL. The mean age at diagnosis of capillary hemangioblastoma of retina in VHL patients is 25 years. Retinal capillary hemangiomas usually occur in the peripheral fundus but can also infrequently occur over the optic disc, and they can be multiple and bilateral in VHL patients. Retinal capillary hemangiomas appear as bright red to orange colored tumor in the retinal periphery, as seen here in this photograph. And the most characteristic feature of this tumor, which suggests its diagnosis, is a pair of markedly dilated, tortuous feeder and drainer vessels running from the tumor to the optic disc, as seen here in this photograph. Retinal capillary hemangiomas occurring over the optic disc, however, may not have feeder and drainer vessels, and in VHL suspects with a family history, a characteristic pair of normal caliber vessels may be visible before the tumor is apparent ophthalmoscopically. In this set of photographs, we find in the central fundus there is a pair of blood vessels arising from the optic disc and exudation in the macula. When we trace this pair of dilated blood vessels to the periphery, we will be able to locate the tumor in the retinal periphery. On further examination of the fundus, we find another such lesion, smaller in size, with dilated feeder and drainer blood vessels, but markedly less dilated than the blood vessels supplying the larger tumor. Retinal capillary hemangiomas can lead to exudative retinal detachment, lipid exudation, intraretinal or intravitreal hemorrhage, and gliosis leading to tractional retinal detachment. These secondary effects can result in profound vision loss and phthisis bulbi. Fundus fluorescent angiography shows rapid transit of dye in the feeder arteriole through the tumor up to the drainage venule with marked dye leakage from the tumor, as we can see in the FFA images of the same patient. Here we can see dye leakage from the second tumor also. Multiple treatment modalities have been advocated for retinal capillary hemangiomas. Small posterior and peripheral tumors can be treated by laser photocoagulation. Larger peripheral tumors can be treated by cryotherapy. Large lesions with extensive exudation can be treated by radiotherapy, and PDT has been recommended for lesions on the optic nerve. For laser therapy, the tumor as well as the surrounding retina is coagulated. Earlier treatment of smaller tumors prior to occurrence of exudation is more successful in preserving the vision of the eye, and anti-VEGF injections may help in resolution of serous retinal detachment prior to administration of laser or cryotherapy. Neurological features of patients with VHL include hemangioblastomas in the brain and the spinal cord, as we have mentioned, and the most common site of hemangioblastomas in the brain in patients with VHL is the cerebellum. This series of imaging photographs in VHL patients show hemangioblastomas in the cerebellum, in the medulla oblongata, and in the spinal cord. Hemangioblastoma typically appears as a hyperintense lesion within a cyst. Cutaneous signs occur infrequently in VHL and may include cafe alloy patches and port wine stain, which are more typical of other phacomatoses. Other lesions which can occur in VHL patients include clear cell carcinoma of the kidney, which can be bilateral in 75% of the patients, pheochromocytomas, islet cell carcinoma of the pancreas, and cysts in the kidneys, pancreas, ovaries, and epididymis. Here in this photograph, we see CT scan of a patient with bilateral pheochromocytomas affecting the adrenal glands. VHL suspects must be sent for genetic diagnosis. If positive, they should undergo periodic ocular examination, particularly with wide field fluorescent angiography, to detect new lesions early, to treat them when they are small, and periodic systemic evaluation to rule out the occurrence and development of benign and malignant lesions in non-ocular tissues. VHL patients have reduced life expectancy because of intracranial hemangioblastomas and renal cell carcinomas. Encephalophageal angiomatosis, also known as Sturge-Weber syndrome, occurs due to somatic mosaicism of GNAQ gene located in chromosome 9. So they are not inherited typically. They are usually unilateral and only very infrequently bilateral. When unilateral, all the features of the syndrome occur on one and the same side of the body. The typical features of Sturge-Weber syndrome, port wine stain, choroidal hemangioma, and leptomeningeal hemangiomatosis, are congenital and are present since birth. This is important to remember because this is unlike most clinical features of other phacomatoses, which appear few to several years after birth. The most typical cutaneous feature of Sturge-Weber syndrome is the nevus flammeus or the port wine stain, as seen here in this photograph, which appears as a flat to thickened lesion, pink to violet in color, and most commonly it appears in the dermatome of the first division of the trigeminal nerve, and infrequently it involves the dermatomes of the second and third divisions of the trigeminal nerve also. It is composed of dilated capillaries in the deep dermis, and alone this lesion is not pathognomonic of Sturge-Weber syndrome. It can be treated by cosmetic laser therapy, which can effectively make this lesion disappear or fainted. Here we see that later in life the lesion becomes more thickened and nodular. In the eye, Sturge-Weber syndrome can involve any portion of the ocular vasculature, and we can find episcleral and conjunctival vascular anomalies as seen here in this photograph, iris heterochromia, retinal vascular anomalies, but the most characteristic feature of Sturge-Weber syndrome is diffuse cavernous hemangioma of the choroid. It is composed of mature choroidal blood vessels involving the posterior pole or the entire fundus. It appears as homogeneous deep red coloration of the fundus, known as tomato ketchup appearance of the fundus. It is difficult to diagnose as it involves the entire fundus, and it is typically detected by the different coloration of the affected fundus and the contralateral normal fundus. It thickens slowly over time. Diffuse choroidal hemangiomas are asymptomatic early in life, but later can cause visual compromise due to degeneration of the overlying retina, but more importantly from non-rhegmatogenous retinal detachment. B-scan ultrasound shows moderately reflective diffuse thickening of the choroid with a deep optic cup. Diffuse choroidal hemangioma patients with serous retinal detachment affecting vision should be treated with photodynamic therapy or with radiotherapy. We will be discussing the treatment of choroidal hemangioma in a later session on benign intraocular tumors. Diffuse choroidal hemangioma can rarely occur with congenital ocular melanocytosis. Glaucoma occurs in 70% of patients with Sturge-Weber syndrome, and the raised intraocular pressure in Sturge-Weber syndrome is said to occur from raised episcleral venous pressure, angle malformation, or ciliary body hypersecretion of aqueous humor. The raised intraocular pressure results in optic disc cupping. However, a deep optic disc cup in Sturge-Weber syndrome is more frequently from the peripapillary choroidal thickening from the diffuse choroidal hemangioma, and it is said that glaucoma in Sturge-Weber syndrome is more common in patients with angiomatosis in the ocular and periocular region. Sturge-Weber syndrome patients having early onset glaucoma requires filtering surgery, and it is very important to remember that filtering surgery in these patients is associated with a high risk of intraoperative or postoperative choroidal detachment and choroidal hemorrhage. Late onset glaucoma in patients with Sturge-Weber syndrome is more amenable to medical therapy. The typical neurological feature of Sturge-Weber syndrome is leptomeningeal hemangiomatosis occurring on the same side of the port wine stain. The leptomeningeal hemangiomatosis can involve frontal, parietal, temporal, or occipital lobes of the cerebral cortex or the cerebellum, and the hemangiomatosis causes exudation of fluid, atrophy of cerebral cortex, and calcification of meninges. So here we see atrophy of the cerebral cortex on the involved side and calcification of the meninges, and these results in seizures, focal neurologic deficits, and variable cognitive impairment. As we have mentioned, like other features of Sturge-Weber syndrome, leptomeningeal hemangiomatosis is congenital and progressively grows throughout life. On contrast, imaging early lesions appear as cortical vascular malformations following the pattern of the gyri of the cerebral cortex. Benign or malignant neoplasms do not occur in Sturge-Weber syndrome patients, but these patients can have reduced life expectancy from profound mental retardation and intractable seizures. Poor visual acuity can occur in patients with Sturge-Weber syndrome due to chronic serous retinal detachment and glaucoma. Ataxia telangiectasia, also known as Lewy body syndrome, is an autosomal recessive disorder unlike other phacomatoses with mutation in chromosome 11. Ocular features of ataxia telangiectasia start with motor defects, with the patient demonstrating failure to initiate saccades and generating head thrusts to shift gaze from one target to another. Conjunctival telangiectasia, as seen here in this photograph, occurs between 3 to 5 years of age, and it is initially interpalpebral and away from limbus, but then becomes generalized, involving the entire conjunctiva. Neurological features of ataxia telangiectasia include ataxia apparent by second year of life, dystonia, dysarthria, and chorioathetosis. Severe motor disability occurs by 10 years of age. And in the skin, telangiectasia occurs in sun-exposed areas, including the eyelids in patients with ataxia telangiectasia. Other features which can occur in patients with ataxia telangiectasia include thymic hypoplasia and decreased T cell function, leading to malignancies and respiratory infections, which are the major causes of mortality in these patients. Ataxia telangiectasia patients also demonstrate increased sensitivity to radiation and chemotherapeutic agents. Incontinentia pigmenti or Bloch-Schulzberger disease is an X-linked dominant disease, so lethal in male fetus and found only in females. Ocular features of incontinentia pigmenti include proliferative vitreoretinopathy resembling retinopathy of prematurity. It is typically unilateral or highly asymmetric and can lead to cataract, glaucoma, strabismus, and nystagmus. Neurological features include seizures and mental retardation. Cutaneous features occurring in patients with incontinentia pigmenti include erythema and bullae appearing in the first few days of life, particularly in the extremities, and persisting for months to few years. Later, hyperpigmented macules occur in groups, typically on the trunk, in a splashed paint pattern, as seen here in this photograph. Rismos angioma, also known as Wyburn-Mason syndrome or Bonnet-de Chamblanc syndrome, is a non-hereditary sporadic disease. characterized by congenital arteriovenous malformation of the retina and the brain. They are usually small in size and birth and progresses with growth of the patient. It is unilateral, with the lesions in the retina and the brain occurring on one and the same side of the body. The characteristic ocular feature of Wyburn-Mason syndrome are markedly dilated and tortuous blood vessels in the retina without any capillary bed, as seen in these photographs. Being arteriovenous anastomosis, they shunt blood from arteries to veins, but they do not leak, as seen in this fluorescent angiogram. Visual acuity in Wyburn-Mason syndrome varies from normal to severe visual impairment, and it is said that approximately 50% of patients with Wyburn-Mason syndrome have severe visual impairment. There can be vitreous hemorrhage and secondary iris neovascularization from retinal ischemia in Wyburn-Mason syndrome, and the retinal ischemia in Wyburn-Mason syndrome is said to occur due to kinking of a loop of the arteriovenous malformation, which leads to spontaneous occlusion of a sector of the retina. Here we find CRVO occurring in a patient with Wyburn-Mason syndrome. The racemose angioma of Wyburn-Mason syndrome should be distinguished from a congenital retinal macrovessel whose branches cross the horizontal meridian, often through the macula. Cutaneous features of Wyburn-Mason syndrome include arteriovenous malformations of the skin, which may occur in the face and in the orbit. And neurological features of patients with Wyburn-Mason syndrome include arteriovenous malformations in the midbrain occurring ipsilateral to the eye, having the retinal arteriovenous malformation. Not all patients with retinal arteriovenous malformation have intracranial arteriovenous malformation, but those with more complex retinal arteriovenous malformation have a higher likelihood of having intracranial arteriovenous malformations also. And arteriovenous malformations in the brain can cause seizures, focal neurologic signs, and intracerebral hemorrhage. Other features of Wyburn-Mason syndrome include maxillofacial and mandibular AVMs, which can bleed during dental procedures. So patients with Wyburn-Mason syndrome can have retinal ischemia leading to significant visual decline, and early deaths can occur in these patients from bleeding from the intracranial arteriovenous malformation or stroke resulting from the treatment of these intracranial arteriovenous malformations. Klippel-Trenaunay-Weber syndrome or KTWS occurs due to somatic mosaicism in PIK3CA gene located in chromosome 3, and KTWS is said to be one of the PIK3CA related overgrowth spectrum disorders, also called PROS disorders. Ocular features of KTWS includes vascular anomalies and glaucoma. Neurological features of patients with KTWS include seizures and gliomas in the optic nerve and chiasma. Cutaneous features such as nevus flammeus, but limb hypertrophy is the most characteristic feature of KTWS and occurs due to a vascular nevus which causes varicosities and hypertrophy of underlying tissues. Kasabek-Merit syndrome can occur due to consumption of blood cells within these lesions. To recap the salient points, phacomatosis are a group of disorders which are characterized by hamartomas in the eye, the central nervous system, and skin. They can also have lesions in other parts of the body. Neurofibromatosis 1 has autosomal dominant inheritance pattern and is characterized by cafe-au-lait spots, cutaneous neurofibromas including plexiform neurofibromas of the eyelids, leash nodules in the iris, optic nerve, and chiasmal glioma. Neurofibromatosis type 2 has autosomal dominant inheritance pattern and is characterized by bilateral acoustic neuromas causing sensorineural deafness, cataract, and combined hamartoma of the retina and the retinal pigment epithelium. Tuberous sclerosis has autosomal dominant inheritance pattern and is characterized by retinal astrocytic hamartomas, CNS astrocytomas, ash-leaf spots, facial angiofibromas, subungual and periungual fibromas, and shagreen patches in the lower back. Von Hippel-Lindau disease is a highly penetrant autosomal dominant disorder characterized by retinal and intracranial hemangioblastomas, renal cell carcinoma, and pheochromocytoma. Sturge-Weber syndrome is a non-hereditary sporadic disease characterized by ipsilateral nevus flammeus, glaucoma, diffuse choroidal hemangioma, and leptomeningeal hemangiomatosis. Wyburn-Mason syndrome is also a non-hereditary sporadic disease characterized by ipsilateral, retinal, and intracranial arteriovenous malformations. Ataxia telangiectasia is an autosomal recessive disorder characterized by ocular movement abnormalities including failure to initiate saccades, conjunctival telangiectasia, ataxia, and immunodeficiency-related infections and malignancies. Incontinentia pigmenti is an X-linked dominant disorder characterized by proliferative vitreoretinopathy and skin pigmentation in a splashed paint pattern. Thank you for listening.